then there's no role for us, actually, to be honest with you. So the newer therapies has to happen.
Yeah, that's exciting.
So
And they cross many specialty lines, which is exciting, right? New
right,
drugs used to be only restricted to a field, and now they have
right,
so many uses across a bunch of specialties. So, well,
correct,
we're
yeah.
at 12:01, so we're ready to get started. Welcome to another May edition. Hard to believe we are in May of our Department of Internal Medicine Roy Benke Grand Rounds. We have nephrology as our chosen topic for this Thursday. We have Dr. Naveen Narayanankutty, who is the program director of our outstanding renal fellowship and an assistant professor in our division of nephrology and hypertension, um, run by the great Dr. Claude Basile. So, tell you a little bit about Naveen. So, after completing his studies in medicine in India, at the Kottayam Medical College of India, he came to the U.S. and did his residencies in the Bronx. So, at the St. Barnabas, at St. Barnabas in the Bronx, and then went to Washington D.C., where he worked at Providence Hospital. There in the general internal medicine faculty, very involved in teaching the internal medicine residents, twice being named the faculty teacher of the year. So already we knew he had great teaching prowess. He found himself in Miami following the continuing theme of large cities in the US. So he next went to Miami, where he did his nephrology fellowship at the University of Miami, and then his transplant nephrology fellowship, also at the University of Miami. We were lucky to get him over here shortly thereafter into our division of nephrology and hypertension. Naveen quickly established himself as a fantastic teacher, being extremely involved in fellows and residents oral case presentations, abstracts, very, very nice collection of scholarly activity already in his young faculty career. And then he became program director. It seems like it's been forever ago, but took over for Dr. Lopez as program director in July of 2024. Was that correct, Naveen? Or 2023?
3.
2023. It just seems so long ago. So July of 2023. You never know that Naveen has only been a program director for 2 years, because he's just done an incredible job of really revitalizing the fellowship. Had an incredible match. Congratulations, Naveen. All 5 slots matched in this year's fellowship. And I think he's just an absolute reflection of our outstanding young faculty that we've been able to recruit in the last half decade to USF. So with that, Dr. Naveen Narayanankutty, or as he says, call me Dr. Naveen, will do the role of primary care physicians and nephrologists in the management of diabetic kidney disease. And as he writes there, and many of you caught our discussion, our pregame discussion before, really the approach on the newer therapies, the focusing on the newer therapies. So, Dr. Naveen, take it away.
Super. Thank you very much, Dr. Lazama, for the very kind introduction. So welcome you all to today's Grand Rounds. And as Dr. Lazama mentioned, the topic which I chose, when I decided to choose the topic, I decided to choose this one because this is an upcoming field. Even though some of the medications we've been dealing with, diabetes and diabetic kidney disease, were there for ages, it is this particular era where expanding more and more clinical trials are coming. Just like in the field of oncology or hematology, I think endocrinology, nephrology, primary care is also evolving. And it is important that we should bridge the gap, if there is any, in prescribing the right medications for our patients, so that we can make a significant impact on the life of our diabetic patients. So I will divide this talk into two sessions, or 2 halves, which means the first 15-20 minutes I'll talk about kidney disease, chronic kidney disease, and then I'll move to the treatment of diabetes and diabetic kidney disease. Once again, thank you for all of you who have joined this today. So I have no disclosures. The objectives of my talk are to define chronic kidney disease, recognize risk factors for chronic kidney disease, recognize newer therapies for the treatment of diabetic kidney disease, recognize the role of primary care physicians and nephrologists in the management of diabetic kidney disease, and discuss ongoing clinical trials in the field of diabetic kidney disease. So we'll start with 3 cases, and I just want you all to just keep this and remember this towards the end of the talk, because if I can convince you to manage these cases, then this talk is a success. So the first case is an overweight with a BMI of 35 patient with diabetic kidney disease, stage 3A, with the UACR of 52 milligrams per millimole and uncontrolled diabetes with an A1C of 9.6 comes to see you in the clinic. And the question is, how do we manage? The second one is a lean patient with heart failure and diabetic kidney disease with a GFR of 53 comes to see you in the clinic. His diabetes is well controlled. And the third patient is a patient with hyperkalemia, sorry for the spelling, near normal glycemia and diabetic kidney disease. And GFR 44 comes to see you in the clinic. And let's see how can we help these patients moving forward. Chronic kidney disease, sorry. So chronic kidney disease is defined as abnormalities of kidney structure or function present for more than 3 months with implications for health. Definition includes different markers of kidney damage, eGFR, ACR, albumin creatinine ratio, and the cause of chronic kidney disease should be actively sought. So why is it important that we have to, focus our mind or our treatment approach towards chronic kidney disease? Is that if you look at the studies, there is 1 in 10 people in the general population have chronic kidney disease. In the United States, that is 1 in 7. And it's the 9th leading cause of death. It was the 9th leading cause of death in 2019 data, and it's predicted to be the 5th leading cause of death by 2040. So the definition, as I mentioned, it includes abnormalities in kidney structure or function for more than 3 months, and it should be classified according to cause, GFR, and ACR. So the causes, the number 1 cause is diabetes mellitus. About 44% of the patients with chronic kidney disease, the cause is diabetes. The second is hypertension. And you have GN about 7% and polycystic kidney disease about 1.6%. GFR, let's focus on these 3, as I mentioned, CGA. So let's focus on the GFR. This is the latest KDIGO recommendation by 2024. In adults at risk of CKD, we recommend use of creatinine-based eGFR calculation. However, if cystatin C is available, which our facilities do, we can order cystatin C. The GFR category should be estimated from a combination of creatinine and cystatin C based equations. Now, we all know the stages of chronic kidney disease, but I'll mention it quickly. We have stage 1 through 5, the GFR more than 90, 60 to 89, 45 to 59, 30 to 44, and 15 to 29, which we call it severely decreased, and less than 15 as a kidney failure. Then A, the albuminuria categories in CKD, we have A1, A2, A3. Before we used terms like microalbuminuria, but presently we use like normal to mildly increased, then moderately increased if it's 30 to 300 milligrams per gram, and if it's more than 300, we call it severely increased. In this slide, we are all familiar. On the y-axis, you have GFR and albuminuria on the x, and we can see that the GFR, this is called a heat map. I like to call it a heat map because the more red the area we move, more the prognosis is bad and more adverse outcome we have for these patients, especially for a patient with G4 and A3. There's the the relative risk of adverse outcomes is higher. So as a next step, once we see a patient in the kidney clinic or in a primary care setting, we all have to think what all investigations will guide us in determining the cause. For example, exam, then you always have to look at this, urinary tract infections or abnormalities. Social and environmental history is very important. A careful family history for possible genetic causes is super important. And we can, always examine and look for symptoms and signs of systemic disease. And the most important part, which I always tell the fellows, is review the medications. And I for fellows who rounded with me or residents who rounded with me, I always say you review the medications in the inpatient setting or clinic setting every single time. Sometimes at Tampa General Hospital, we have to review it a couple of times a day because there's a lot of moving things there. So in order to assess on a day-to-day basis, that's super important. Laboratory tests, we order common tests. Urinary sediments are important. Urine albumin creatinine ratio, serological tests, ultrasound, kidney biopsy, and genetic testing as indicated. Now, I want all of you to focus on this particular slide. Why is it important? So on the left, on my left side, the age is less than 65, and the other one is age more than 65. No matter what, if you focus your attention to the GFR of 60 or below, even if they do not have albuminuria, the relative risk of adverse outcome is high. Look at the cardiovascular mortality. GFR less than 60, 2.5, even without albuminuria, right? So this is super important to understand. And this is a concept we all need to keep in our mind when we see our patients. The second most important part is there is a thing called aging. We all have heard from our patients, or sometimes ourselves also, after the age of 40, things are different. Things are not as same as before 40. So the same happens with the kidneys. There is nothing like a healthy aging in kidney because it is not associated with the preserved GFR. So when you think about GFR decline after 40, we all lose about 0.5 to 0.6 ml per minute per 1.73 meters square every year, no matter if you have, no other medical problems and if you're healthy. So that should be understood. The second important part, which we all have to make sure is we recognize is there are different categories. One is, the first is acute kidney injury. If a patient has normal creatinine at baseline, and the definition of acute kidney injury is increase in serum creatinine by 50% within 7 days, or increase in serum creatinine by 0.3 milligram per deciliter within 2 days, or oliguria more than 6 hours. That we all know, we deal with this every time in inpatient setting. Then we'll skip the second part. We'll look at the CKD. As I mentioned, it's more than 3 months, GFR less than 60, and or with markers of kidney damage. Then you have no kidney disease, GFR more than 60, no kidney damage. Okay. Now the second column here, it is called acute kidney disease. This is what we miss. This is most of the time what we miss. For example, a patient gets discharged from the hospital. If that patient is admitted for AKI and the creatinine is not back to baseline, I always tell my fellow to give a follow-up appointment in the clinic within 2 weeks. Why is it so important? Because if the patient remains in an acute kidney injury for more than or like up to 3 months, that is called acute kidney disease, and they start manifesting markers of kidney damage, including albuminuria, hematuria, or pyuria. So it is at this phase where we all have to pitch in. So it's super important that if you see a patient in the clinic, in a primary care setting or in a kidney clinic or any clinic, that you see a patient has acute kidney injury, we have to see them before 3 months. Don't let, so come back in 3 months, come back 4 months. No, we have to see them closely because we don't want them to go into a phase of acute kidney disease. Now, this slide is super important. Now, the dark line on the top is A, and the second and the bottom line is B. Like, imagine if you have a patient A and patient B. So both of them developed acute kidney injury, and their recovery is very similar. Let me see if I can point. Okay, laser pointer. Can you see my pointer?
Yes.
Yeah. Okay.
Yeah,
so both of them. Well. Super. So both of them, like A and B, both of them had acute kidney injury. They all recovered to a similar GFR, but we all can agree that patient A has residual decrease in eGFR relative to the baseline, correct? Because here's GFR is here, but he started off with 120 higher. So there's a residual decrease in GFR for that patient A. This is super important. This is super important when we evaluate a patient and when we see in the clinic. Rather than looking prospectively, it's always important to look retrospectively. How much GFR this patient lost, even though he had some recovery. Now, we'll come to diabetic kidney disease. So chronic kidney disease is presently nearly half of the people with type 2 diabetes and 1/3 in type 1. Chronic kidney disease is associated with increased risk of kidney, cardiovascular, and mortality outcome, which I showed you on the slide. Both albuminuria and reduced eGFR are independent and additive risk factor for cardiovascular events. What are the risk factors? We all know a lot of risk factors, which is non-modifiable, including age. But what are the risk factors which we can have an impact on or modify? Poor glycemic control, number one. Hypertension, combined together, super bad combination. Dyslipidemia, socioeconomic disadvantage, that's one important thing. Sedentary lifestyle, obesity, tobacco use has shown to cause a lot of pathology in kidneys, including changes of secondary FSGS, insulin resistance or metabolic syndrome, chronic infections, recurrent and chronic infections. There is a fancy term which I always test the fellows with. When you have recurrent chronic UTIs, there is something we see in the kidney which is termed as malakoplakia. Episodes of acute kidney injury, advanced glycation end products, OCP use, hyperuricemia, vitamin D deficiency. We can have some modifying factors here, if you know this. The pathophysiology of diabetes is pretty complex because it involves an interplay between hemodynamic variations, metabolic derangements, and fibrosis. So this slide is a little complex, but I will put it simply, is that the key player is reactive oxygen species. When you have hyperglycemia inside the cell, there is reactive oxygen species is activated, which in turn will activate pathological reactive species, and eventually which results in a DNA damage and activation of PAR pathway. What the end result is, if you look at the left-hand side of this slide, is you block the glycolysis. So you have glucose, G6PD, fructose 6, glyceraldehyde 3-phosphate, diphosphoglycerate glycolysis, and that pathway is blocked. So when that pathway is blocked, there is advanced or early glycated products, which goes into a pathological pathway, and which ultimately the root cause is that there is a lot of inflammation and there is fibrosis. The second important part is tubulointerstitial fibrosis, which happens in the kidney. So, which is also through the translocation of mesenchymal fibroblast. So there is, a lot of fibroblasts moving into the tubulointerstitial space, and which results in fibrosis. This is also factored into the pathology of diabetic kidney disease. This slide shows you two parts. One, the top part is the diabetic kidney. The bottom part is a healthy kidney. So what you see is in diabetic kidney, there is, afferent arterial dilatation. There is mesangial cell hypertrophy, as you can see there, here. And then it also causes changes in the podocyte, which results in podocytopathy and podocyte loss and food process effacement, which is eventually lead to albuminuria. There's also epithelial and tubular cell atrophy as well. So these are the changes, if you look at a molecular level, we see in diabetic kidney disease. Now, this is a slide taken from our kind of lab, which shows, what we call it nodular lesions in diabetic kidney disease, thickening of GBM. So pathologically, there's 4 classifications. Class 1 is mainly we see, you will see, like if you get a biopsy, if you do a kidney biopsy, you would be seeing the pathologist writing, oh, it's class 3 diabetic nephropathy, class 4. What it means is class 1 and 2, early on in the disease, we have some mesangial expansion. If it's class 2A, it's less than 25% of mesangial is expanded, or if more than that, then it's class 2B. And 3 is nodular lesion, we call it Kimmel-Steele-Wilson nodules, and advanced glomerulosclerosis, class 4. So this is another exciting area which we've been working on for years, but we haven't reached anywhere yet. Now, there are different biomarkers have been tested. This is some of them. There's a lot more, and these are taken from the 2023-24 paper. Cystatin C, as I said, it's available. There's focus on NGAL, KIM1, copeptin, but out of that, keep an eye for this particular marker, CKD273, which is proteomics based. The science is, the field is advancing in that direction really fast. And in the coming few years, we will hear more and more about this particular molecule. There are a lot of genes involved. It's not ACE-I, it's ACE, ApoE. But if you look at the genes which are involved, everything will focus on either going into a hypermetabolic pathway or fibrogenesis or lipid metabolism. Lipid pathway is also gaining a lot of importance in the diabetic kidney disease. There are a lot of researchers looking at lipid accumulation in the kidneys resulting in fibrosis, and what drug discovery is also focusing on this particular area. And let's focus on, that's what are we doing at 12:23. Okay, so let's focus on the treatment. So when you focus, when you think about the treatment, the focus should be on the pathways which I mentioned, like how to prevent hypermetabolism or metabolic derangements, how to target hyperfiltration, how to target fibrosis. So the newer medications are targeting these particular areas to make an impact. Like I mentioned, the GFR in healthy kidney, in healthy aging, is still you lose about 0.5 to 0.7. If you're a diabetic patient, you may lose somewhere between 4, 5, 6 cc's per minute per year. So how can we get better at that particular area? That's the focus when a nephrologist see a patient in the clinic. When I see a patient in the clinic, I look at the graph, I look at the trajectory, I look at the rate of decline of GFR every year and see how much we can add. Is there a room to add a new medicine? So that's very, very important. Now, this slide is also super important because unlike any other disease, there are different phenotypes for kidney disease, diabetic kidney disease. The classic diabetic kidney patient is on the top one. You start with the GFR more than 90, you start slowly to develop mildly increased albumin to severely increased albuminuria, and then you see a sudden drop in GFR. Then there is a subset of patient where you develop a little bit of albuminuria, but it regresses back and get better. And then there is another one, which is no matter what, GFR continue to decline from the beginning, and proteinuria worsens as well behind GFR. And there is a non-proteinuric kidney disease. That part, the section 4 or the patient 4 is super important as well, because here we have a patient without albuminuria but have diabetes. So if you look at the baseline characteristics of these different phenotypes, you can see the classic patient is normally an older agent with obesity, uncontrolled hypertension, and albuminuria. So if you biopsy that patient, this is exactly what it's going to see, what I mentioned in the slide. You can see mesangial expansion and GBM thickening, some nodularity there, and interstitial fibrosis. And there are a lot of prognostic markers, but look at that, urinary proteomic risk classifier CKD27. They are testing that in this particular category of patients. Then the second group, where you get albuminuria to regress, you can have some, not as much of GBM thickening, and things can get better as well. And you can see some clearance of nodular lesions, and nobody knows why it happens. And the rapid decliners, starting with significantly nodularity and arterial or anhydrinosis and significant IFTA. A lot of biomarkers also, KIM1, CD27, all those urinary biomarkers also being tested. Then there is non-proteinuria kidney disease. But look at the biopsy finding of non-proteinuria kidney disease. It shows a lot of atypical glomerular changes. It also shows increase in GBM width and mesangial, shows diffuse and nodular lesions and tubular interstitial vascular lesions. So we should not be fooled by this particular category of medicine, of patients. So the target should focus on hyperglycemia, hyperfiltration, inflammation, and fibrosis. So the first category of medicines we've been using it for ages is RAS inhibition. As we all know, Ang2-mediated vasoconstriction is a problem. And when you use RAS inhibition, we can get efferent arterial dilatation and decrease in hyperfiltration, which can get things better. So old trials or the trials which have shown efficacy with the use of RAS inhibition, there are 3 of them. The first is the CAPTOPRIL study in 93, then IDNT and RENAL study. And if you look at all the patient population, they are type 2 diabetic and with diabetic kidney disease. The primary outcome was composite doubling of serum creatinine and onset of kidney failure and death. Look at the hazard ratio, 0.8, 0.84. So about 20 to 16% decline in the reduction in the primary composite outcome. So this is the original slides taken from the original study published in New England Journal. This is a RENAL study showing a 16% risk reduction after treating with losartan, an IDNT study showing about 20% risk reduction as well. So this is the latest guideline, which is taken from recently published in Kidney International, the KDIGO guideline. So look at the words they're using and pay close attention to it. So we recommend starting RAS inhibition or ARB for people with CKD and severely increased albuminuria from stage 1 to 4 with A3 without diabetes. So if you have a CKD patient, even without diabetes, but there is albuminuria, that's a recommendation. So 1B recommendations to start RAS inhibition. I'm a little shy to start RAS inhibition on stage 4 if they are not new, but this is a recommendation. Now, the second one is a suggestion because it's a grade 2C recommendations. We suggest RAS inhibition for people with chronic kidney disease and moderately increased albuminuria without diabetes. So if you have a chronic kidney disease, but not severely increased albuminuria and no diabetes, so there's no diabetes, but albuminuria is moderate, then they suggest. And the third one is they recommend RAS inhibition for people with chronic kidney disease and moderately to severely increased albuminuria with diabetes. So if you have diabetes and significant albuminuria, no matter what, you have to start. And we recommend avoiding any combination, no ACE or ARB combined or direct renin inhibitor therapy in chronic kidney disease with or without diabetes. It's in recommendations against it. So why is it important that we showed that there is some significant residual risk reduction, about 16 to 20% with the use of RAS inhibition? But why is it important that we have to have a newer therapies? So the money is there. It's like, if you look at the graph, there is still a significant residual risk for these patients. So we really need to pitch in and find newer therapies. And that made to the discovery of SGLT2 inhibitors. So as you know, SGLT2 inhibitors, sodium glucose cotransporters 2 inhibitors, where they act is mainly on the proximal collecting tubule. So this first diagram, this is taken from Nature Reviews, a super wonderful diagram done by Dr. Catherine Tuttle and group, and she's one of the famous persons who gives talk on SGLT2 as and newer therapies. So so what it shows is, this is a diabetic kidney patients. So you have increased absorption of sodium and glucose, reabsorption of the proximal tubule via SGLT2 in diabetic patients. So what happens is there is decreased delivery of sodium towards the macula densa, and through a nitric oxide mediated pathway, there is afferent arterial or vasodilatation. This is what happens in diabetic patients. So, and because of this, it causes a lot of hyperfiltration. Proximal tubule will have to work really hard, which results in oxidative stress and cause kidney damage. So SGLT2 inhibitors does the opposite. It blocks this, so there is no problem in tubular glomerular feedback in macula densa, and it helps to prevent hyperfiltration through this pathway. There are also multiple other mechanisms, which includes TNF alpha, interleukin 6 and stuff, but this is the main mechanism how SGLT2 inhibitors work. What are the trials with so far available, which proves that this medicine is important? So 3 trials. One is the Credence trial in 2019. Then you have DAPA-CKD in 2020 and EMPA-CKD in 2023. What they looked is, they looked at all of them have type 2 diabetic patients. In DAPA-CKD, there's also non-diabetic CKD patients, and EMPA also. If you look at the hazard ratio, look at that, it's like 0.7, 0.61, 0.72, significant residual benefit in risk reduction. So so the study population, to put it simply, the Credence, we have about 4,400 people, DAPA 4,300, and EMPA 5,000 people. eGFR in this particular group was between 30 and 90, with a USER of 300 to 5,000 milligrams per deciliter. In the DAPA group, 25 to 75 eGFR, and in the EMPA, 20 to 45. Or if it's a little bit higher, eGFR group should have an albuminuria. Looked at the composite end-stage kidney disease, doubling creatinine, serum creatinine, renal and cardiovascular death, all the group. And as I mentioned, the hazard ratio is such that there is significant residual benefit which we can observe in these 3 categories, clearly in DAPA group. Now, what does the KDIGO recommend? So the KDIGO recommend treating patients with type 2 diabetes and chronic kidney disease and eGFR greater than or equal to 20 cc's per minute with an SGLT2. It's a grade 1 recommendation. So you have a patient with type 2 diabetes with GFR is more than 20, you can use SGLT2 inhibitors, or you should use SGLT2 inhibitors. Then the second recommendation is to adult patients with CKD, eGFR more than 20, and albuminuria or heart failure. So if there's heart failure, doesn't matter. If GFR is more than 20, you can use. If you have CKD and albuminuria more than 200, start it. Suggest treating adults with eGFR 20 to 45 with, even if the GFR even if the albuminuria is less than 200, you could consider, as a suggestion, it's not a strong recommendation. So the first 2 categories, type 2 diabetic, even though the GFR is, if the GFR is more than 20, and CKD, started. The second, CKD with a little bit of albuminuria or just heart failure itself, you can start it. Adverse events. The main adverse events are genital mycotic infections, ketoacidosis. It can cause volume depletion through natriuresis effect, there is some risk of amputation, especially in non-CKD population. Hypoglycemia risk is also there, and these are the measures which we can tell the patient when you see the patient in the clinic. You can mention to them, how to prevent and how to monitor these things. So daily hygiene, dose reduction. So especially this is very important. If a patient is on SGLT2 inhibitor, and if you know that the patient is going for a critical, like a surgery or prolonged fasting, or have some critical medical illness, either the recommendation is to have a dose reduction of diuretics if they are using those. Again, the importance why. So we have two things now to use in CKD and diabetics. We have RAS inhibition, we have SGLT2 inhibitors. And why is it important? Why is it important that, to find another treatment still, because there is still residual risk of adverse outcome. That then comes the mineralocorticoid antagonist, which they did a study in 2020. It is called Fidelio DKD study. And there's a counterpart of that is Figaro in heart outcome, and combined together is Fidelity. So there's 3 studies, but for the interest of time, I will quickly go through the Fidelio DKD study, which enrolled 5,734 patients with type 2 diabetes and diabetic kidney disease, looked at the composite of 40% reduction in eGFR, onset of kidney failure from failure and death from renal causes. Hazard ratio 0.82. It was a multi-center, double-blind, placebo-controlled randomized controlled trial, finerenone versus placebo. Diabetic patients plus albuminuric chronic kidney disease. GFR 25 to less than 60. UACR 30 to less than 300. So in the moderate category of albuminuria with a GFR of 25 and above, maximum tolerated, all these patients are on max tolerated ACE or ARB. What did it show? 18% risk reduction in this group. So we have one more pillar. So we got RAS inhibition, we got SGLT2, we got finerenone, which shows improvement in the composite outcome. So what does KDIGO recommend? The new one suggests non-steroidal mineralocorticoid receptor antagonist with proven kidney or cardiovascular benefits for adults with type 2 diabetes and eGFR more than 25, like the study did. Normal serum potassium, because the most common side effect is hyperkalemia, and albuminuria more than 30, despite maximal tolerated RAS inhibition. So it's a suggestion, it's a great two-way suggestion. So, but if you have a patient who is on maximally tolerated RAS inhibition with normal potassium, you can consider this, provided they have a little bit of albuminuria. Side effects. Main side effects, hyperkalemia and decrease in GFR. So it's important that we compare with steroidal versus non-steroidal. So spironolactone and eplerenone are steroidal, and you have finerenone. So what is the difference? The structural properties in non-steroidal are a little bit bulkier, and it doesn't make any active metabolites compared to spironolactone. Sexual side effects like gynecomastias are none in finerenone group. Half-life is short, 2 to 3 hours compared to 20-hour half-life in spironolactone. Look at the effect on BP. It doesn't lower the blood pressure that much as spironolactone does. So if you have a patient who's diabetic, a little bit, hypertensive, with chronic kidney disease and a little bit of albuminuria, you can consider this for because it's highly potent and it does not have CNS penetration. So you can consider this medication, which comes in the brand name Kerendia. So the management, it's very important. The problem we have is that we start patients on medicine and we take them off when we see hyperkalemia. So it is very important we have to have a uniform approach how we deal with these patients, because studies have looked at stopping these medications, like stopping RAS inhibition. They found the composite cardiovascular outcome, major adverse cardiac events like MACE, was significantly higher, but kidney-related outcome was better, but clearly so. But you have, when you stop these medicines, your risk profile or cardiovascular mortality or adverse outcomes increases. So it's important we target the right population to start this medicine and keep it as much as we can without stopping. So the management in case of hyperkalemia is if the potassium less than 4.8, the recommendation is, this is KDIGO recommendation. This is recommendation is to start 10 milligram daily if GFR is between 25 to 60, 20 if more than 60, and you have to monitor your potassium at 1 month after initiation and then every 4 months. So if a patient is on Kerendia, don't tell them to come back in 6 months. You need to at least monitor every 3 to 4 months after your first month visit. You can increase your dose to 20 milligram daily if on 10 milligram. Restart 10 milligram daily if previously held for hyperkalemia and potassium is less than 5 millimoles per liter now. The second is if you have a potassium, borderline high potassium, 4.9 to 5.5, you continue it and monitor every 4 months. If you have potassium more than 5.5, then hold it. Consider adjustment to diet, concomitant medications to mitigate hyperkalemia, recheck, and reinitiation when it's less than 5. So these 3 studies I mentioned, you have your, IDNT, you have your Phenertron and like Fidelio and then DAPA study, still have a problem. There's still significant residual risk in the composite outcome. So then people have looked at glucagon-like peptide. So what is this? It's a hormone which is produced after you eat to give you a sense of feeling of satiety. It also have another action that it slows your gastric motility. It has some diuretic effect. It decreases your blood sugar. It also have, it stimulates insulin secretion, and a lot of actions, like mainly. So people have started looking at GLP-1 agonist, and this is a nutshell of it, where it acts in the intestinal lumen through L cell. What happens is once you eat food, it causes exocytosis of your GLP-1, and which acts through different pathways, endocrine pathway, neuronal or paracrine pathway. Again, this is a diagram showing how hyperfiltration affects your kidneys through vasoconstriction, and GLP-1 can block your receptors in the efferent arteriole. Okay, so this slide shows you the renal risk factors and how does GLP-1 and DPP-4 inhibitor act and what are the effects of it. For the interest in time, focus on obesity, blood pressure lowerment, dyslipidemia, inflammation and fibrosis. So this is a medicine which targets inflammation and fibrosis, and it also have an effect, slight effect on glomerular hyperfiltration. So GLP-1 receptor agonists have impact or effect on inflammation and fibrosis. These are the multiple trials they have done prior to the most important FLOW trial. So FLOW trial, what they did was they looked at 3,533 patients. Mean age was 67, and who have high risk of chronic kidney disease and type 2 diabetes. It was also double-blind, randomized, placebo-controlled, multi-center, and it showed that 24% decline in adverse events. And this study was stopped early at 3.5 years because of the positive outcome. And this is a rare thing to do by FDA, because no studies, and FDA got rapid approval for these medications, because usually they look at the efficacy a lot. But this study, since because of the huge impact, and there is a difference in annual decline in GFR of 1.16 mLs per minute with this particular medication, with a hazard ratio of 0.76. And look at the even p-value, 0.0003. Even with early termination, they achieved a significant p-value. So what does the FDA recommend? In adults with type 2 diabetes and chronic kidney disease who have not achieved individualized glycemic targets despite the use of metformin, SGLT2 inhibitor, who are unable to use this medicine, we recommend a long-acting GLP-1 receptor agonist. So you have a type 2 diabetic patient with chronic kidney disease they cannot tolerate any other medicine, and then you can start this medicine. So I foresee that this medicine will be a first line soon because of it, the effect we are seeing. Then there's another class of medicine with this ET1, which I showed you, and it's on the different vessels. So it's a vasoconstrictor produced by the kidney. Glomerular epithelial cells, mesangial cells, and collecting ducts are increased. So in diabetic patients and chronic kidney patients, this vasoconstrictor effect is increased. So they tried blocking that particular receptor with medications, but what happened was, since it was a non-selective medicine they used, which blocked ET2 as well. ET2's mechanism was to cause natriuresis. So when you block both, it causes more fluid overload situation. So this medicine, was not approved. So it's like, again, hospitalization for heart failure was also higher because of the fluid retention. Now, having said that, this is an era where we have 3 or 4 classes of medicine which we can use, and we have to know if we can combine these medicines and what are the effects. So we looked at it. I was part of the study, and we looked at combination of SGLT2, finerenone, and RAS inhibition. And clearly, there was a 46% risk reduction when you combine RAS inhibition with SGLT2 and finerenone together. The hyperkalemia, which finerenone causes, is negated by SGLT2 inhibitors. So this was accepted in circulation. And we also looked at, RAS inhibition plus SGLT2. Is it superior to RAS inhibition with finerenone? And we found that that is superior. RAS inhibition with SGLT2 has a superior outcome compared to RAS inhibition with finerenone. But if there is a clear indication to use finerenone and cannot tolerate SGLT2, then that is better than RAS inhibition alone. So having said that, we relook at our cases. So for an overweight patient with uncontrolled diabetes, they will benefit from SGLT2 and GLP-1, obviously, right? It will lower the BMI. If you're thin with heart failure, SGLT2, no doubt. And there is no hyperkalemia for this guy. And A1C is controlled. You can add SGLT2 and a finerenone combo. If you have a hyperkalemia, then you can use finerenone. So you can consider this, but again, SGLT2 is a common factor in all these cases. Having said that, we'll come to the last couple of slides. What are the role of primary care physicians? To recognize that there is an entity called acute kidney disease. So don't let the patient go through that phase, and we need to catch and identify that particular group of patients and see them closely in the clinic. If they have signs of kidney damage, refer them to a nephrologist. Screening annually for EGFR and ACR, but if you identify a patient like less than EGFR is less than 60, like I mentioned, maybe more frequently you need to screen them. A fall in GFR more than 20% on subsequent test, or more than 30% in those on active therapies, need urgent evaluation. Doubling of serum creatinine needs to be evaluated by a kidney nephrologist. Recognizing progression to macroalbuminuria may result in rapid decline in EGFR, and early initiation of treatment will have a better outcome in patients with proteinuria kidney disease. So that's most important thing, is to recognize that we have a subset of patients with kidney disease even without microalbuminuria or macroalbuminuria. We have a subset of patients who get discharged from the hospital after acute kidney injury, and we need to see them closely in the first 3 months. Any increase in GFR on subsequent test, any fall in GFR more than 20% in the subsequent test, we also have to identify them and follow closely. Having said that, in the last 2 slides, I will touch base on ongoing clinical trials. There's a lot of trials coming, and which includes design trial Flow trial we already discussed, confidence trial, smart trial, treasure trial. So these all are for type 2 diabetic patients. There are some for type 1 diabetic patients, especially in tandem, which looks at sotagliflozin. This confidence trial looks at finerenone and empagliflozin. There's a trial called EASE trial, which looks at aldosterone synthase inhibitor and EMPA. There is, DEPIC trial. So there's a lot of ongoing trials happening in this field, and in the next 1 or 2 years, we will see more and more of these category medications coming on board, and hopefully we can have a better impact on our patient's life. So this is also taken from the latest KDIGO guideline. So what is an optimal model of care? Diagnose CKD based on cause, GFR, albuminuria. If you cannot find a cause, then it needs referral. If you identify high-risk population, which is 3 to 5%, 5-year risk of requiring kidney replacement therapy, or GFR less than 30, a sustained fall more than 20, like I mentioned, or planning preparation, it needs to be referred to a nephrologist or specialist. Albuminuria, consistent finding of significant albuminuria more than 300, more than 2-fold increase in albuminuria, a consistent finding of ACR more than 700 milligrams per gram, urinary cast needs further evaluation. Then there is CKD and hypertension patients, which refractory hypertension, resistant hypertension, any mineral bone disease issues also needs a referral. So this is in a nutshell about the medications, the target, what they target, and what improvement and what we can expect. So if you look at the bottom, hyperglycemia, medications, GLP-1, SGLT2 targets that. Inflammation is targeted by MRAs, ERAs. RAS inhibition also targets fibrosis. RAS inhibition in SGLT2 targets hyperfiltration. GLP-1 will target obesity, which is a state of chronic inflammation, and that's very important we address that. Atherosclerosis and microvascular disease, GLP-1 and SGLT2 will target that. Hypertension, all of those medicine, non-steroidal with not much of action there. Dyslipidemia, GLP-1 targets that. Key points: diabetic kidney disease associated with substantial morbidity and cardiovascular mortality. The only kidney treatment was RAS inhibition. Now we are moving towards SGLT2 inhibitors, positive outcome with SGLT2 and mineralocorticoid antagonist. Endothelin receptor antagonist, I'm not a big fan of. GLP-1 receptor agonists have been shown to have beneficial effects on surrogate endpoints. The advent of novel kidney protective drugs provides newer therapeutic options for people living with diabetes and kidney disease, but increases the complexity of treatment, so multidisciplinary approach is needed. Combining drugs may enhance kidney protective effect and could potentially reduce the risk of adverse effects that are associated with specific classes. Like I said, SGLT2 plus finerenone may help to negate the effect of hyperkalemia. An important goal of future pharmacological management of diabetic kidney disease is to individualize treatment with optimal drug combinations based on underlying pathophysiology and guided by tissue or serum biomarkers. Proteomic-based biomarkers is also something to watch. And the purpose of this talk is that this is the data from CDC for the use of medications in Florida. ACE inhibition use is up to 62%, but SGLT2 use is only still up to 8 to 12%. So clearly, we have patients with diabetes on multiple medications. We worry about the risk of hypoglycemia, but as I mentioned, a multidisciplinary approach with primary care, maybe endocrinologist, close follow-up, by all of us, and early initiation of SGLT2 inhibitors should be the focus. From VA, from a nephrology fellowship point of view, Dr. Lamarche and team have started an initiative looking at the utilization of SGLT2 inhibitor, which we all can be part of. We can start like a similar project at Taba General Hospital with the help of our primary care doctors and all our doctors, and take a look at at least target for the next 1 or 2 years. So I'll focus on use of SGLT2 inhibitors and see the difference we can make to the life of people. Having said that, that's the end of my talk. Thank you very much. Open to questions.
Thank you, Dr. Naveen. Excellent talk. Open to questions from the group.
No questions? That's good.
It looks like you marveled everybody. And again, a great job, Dr. Naveen.
Thank you very much. I think that's it.
It was very. Thank you very much for the lecture. It was very thorough, very comprehensive, and very important in making sure that now we have all these new therapies to target this devastating condition that is very common. So it's very exciting as a nephrologist or primary care physician that finally we have all these tools to manage this condition. So thank you very much, Dr. Naveen.
Very good. Thank you.
Thank you, Dr. Lamarche, for your comments. Appreciate it. And again, another appreciation in the chat. So Jen has put the CME code there for everybody. So please do not forget to get your credit, your 1 hour credit. They add up, after 18 to 20 in a spring, that's 18 to 20 hours. So I know it's sometimes it's easy to forget to go in and check and do it, but take those 60 seconds to claim your credit through the USF continuous professional development site. Literally, I think I've timed it at probably even smaller than that.
Claude,
thank you, Jen Nuka, for all
you?
your work as always with this. And Dr. Naveen, I think that's it, unless there's another hand. Jen, do you see anything else?
Yeah, I think Claude wanted to say something.
Oh, Claude. There you
go. Hi.
Thank you. The division director himself, of course.
I'm
Go
actually
ahead,
calling. Yes, how are you? Well, honestly, it's a great comprehensive review by Naveen. I want to just highlight the importance of when he mentions that table showing the microalbuminuria for the primary hospitalists and everybody who doesn't work every day on the protein and the urine is, we want to highlight that the rate of progression of diabetic nephropathy is way faster than any other chronic kidney disease. In fact, the creatinine, the GFR can go downhill in no time after you reach the creatinine of 2, right? So it's very important to act early on. It's very important to identify these people, quite honestly, as soon as the microalbuminuria starts increasing. And even the microalbumin is being revised as a definition in the new classification, not even 30 milligram per gram. It's even a little bit lower. So this is why the importance of combining the different modality of treatment that Naveen was showing at a different level, at a different target, because proteinuria is already so much damage happen on the kidney. I mean, the kidney got damaged in type 1 diabetic nephropathy, even without microalbumin, when the GFR, as you all know, we have hyperfiltration. So there are so much basically attention on that stage if we can. So by combining this medication, the purpose is to decrease the hyperfiltration and make the single nephron do less hyperfiltration and for the kidney to get better. Because if we getting this patient advanced, honestly, the cascade will continue despite everything we try to do, right? So it's very important to act early on. And the more medications that comes helping diabetes or helping diabetes and the kidney, like the SGL2 inhibitor, we should be communicating more and try to take advantage of this stuff. But great talk, Naveen. Thank you.
Thank you, Claude. Thank you. Thank you, everyone. I think we are on time, 1 o'clock. We're good.
Yes, of course. That's what Dr. Naveen does, delivers great teaching and in timely, effective manner. So thank you, everybody. Have a great Thursday, and we'll see you next week. Take care.
Thank you. Thank you, Jen. Thank you, Dr. Lazama. Thank you.
You're welcome. Thank you again for a great talk.